and recorded, and the recording will be made available as normal. So apologies for absence. We have Martin is joining us online, but slightly late. This was agreed, that this is a pre-existing from him from before he was appointed. Ditto actually with Damien, who will join us briefly for part 2, or might join us briefly for part 2, but he knew at the beginning and he negotiated at the beginning that he's got his board meetings at Kingston, which he split 50-50 between us and them, and he steps down at the end of the academic year. Are there any declarations of interest? Oh, sorry, yes. Rachel Evans as well has also given us her apologies. She's on a course, a long-term course, a development course. Good. And where are we? So declarations of interest. Has anyone got any declarations of interest that we should know about that aren't already declared? Okay, minutes of the last meeting. Are people happy that those are an accurate record of the last meeting? I'm getting yes from that one. Matters arising. The matters arising, I think, are in progress. The first one around the trust response is actually going to be covered today, so hopefully we can sign that off today. The other one has been around the chair's report, which I have changed, I've added in, and we can reflect on that at the end. And then the last one, which is for Sally, is around whether we use the term patients, clients, service users, and so there's ongoing work to look at that one. And it looks to me as though it might be a mixed picture, and in different places we use different language depending upon the situation. But let's see what comes out of that. Yep. Okay. Thank you. Neil, over to you, please, for the service user and care involvement focus.
Thank you. So today's presentation is about the peer engagement facilitator work. Colleagues might remember that peer engagement facilitator, PEF, is a program funded by NHS England to fund people for 15 hours a week, and we provide training and support. So we've had about 40 individuals go through this process. I think we look after people in our PEF program really, really well. Some organizations, when they canvassed the service users who took part, felt they weren't supported, and those programs were withdrawn. Ours was increased. So I think we have a good track record with that. Today, we thought Yolanda, who is in the subject of the film today, could come to present with me, but she's doing her counselling training, which I think is amazing, because the whole PEF idea is about going from being a user of services to a provider of services. But I'm going to show a short film, and I think this is a very, very interesting use of lived experience, because Yolanda's experience was in mental health. This service is in cardiac rehab, and all credit to Kim and Martina in that service of recognizing the effect of anxiety on how people use treatment, how they seek help, how they can understand the programs that are offered to them. And Yolandi, I think, has got a really, really interesting take on how her experience of anxiety actually can be used in a physical setting. So I think it's a sort of new idea that you don't just use your lived experience in the same setting you were. That gives us a lot of understanding about mind-body interventions. So just going to show the film.
Oh, describe the team that I'm in. So I'm in the cardiac rehabilitation team. And the service that we provide is an 8-week program for patients who have had cardiac problems. So basically getting them back into fitness, how to do it safely. At the end of each session, we have about a 20-minute talk with, or not, the nurse has about a 20-minute talk with them in regards to for example, dietaries, insurances, if you're going to go on holiday, how to change them. So it's quite informative. So we don't let them go straight away. They're monitored throughout the whole of the session. Their heart rates are taken, I think, twice throughout the session, and we do have a board between 1 to 15 in regards to how they're feeling. So they're constantly monitored, and it's for the patients. It's for the patients. Yeah. I think I've been really fortunate. My team are amazing. They've welcomed me in since the first day. They've included me, been really informative in regards to what's happening, which is really handy considering I didn't know much about in regards to like cardiac and stuff like that. They're a really great team, really supportive, and I can see how they. But it's not just myself; it's the whole team. And in regards to the patients, the way they treat the patients, the relationships that they've formed with the patients, from where they've gone to I've forgotten the word because my brain's just gone. From where they've gone to so they have an appointment first. So after 6 weeks that they've had the appointment, the relationship basically starts from the time that they first met them, and then it's really nice to see the kind of bond that everyone forms as well. But in general, they're a really great team. They're a really great team.
Able to, when people are arriving, to be able to welcome them, to be able to just kind of chat to them in a non-medical context is what I think personally is really beneficial. We have had instance where Yolanda, who's with us at the moment, patients have said something to her. They've been coming to the programme for a little while and they've shared something with her that they wouldn't necessarily have spoken to us about, and we've been able to address that. So I think that's the main thing for me in the service that I can that sort of springs to the forefront of my mind about having someone like Yolanda with us.
Yeah, I agree completely. From my perspective as well, she's just a fantastic other pair of eyes to have in the class. She really is. You just take, for example, yesterday, we had 2 patients felt a little unwell during the program. Our exercise specialists were tied up with other people, and Yolanda was there able to just guide the new patients to the next station and the next station, and just keep that whole thing sort of smoothly running while we dealt with the other stuff. And it was really only a case of showing them to go to station number 2 and then show help. And her people skills are excellent, absolutely excellent. She is so approachable. So we do have 1 in a million with her, really.
Yeah, I mean, definitely giving someone a chance, and it might be something that person may have wanted to get into before, but because of what's happened to them previously, they haven't been able to. But maybe stepping into that role has opened basically a whole new basically door for them, and it's something that they may have not thought about going into before. And yeah, it's just about opportunities. And learning, definitely learning, because I've learned a lot in the 3 months that I've been there. So yeah.
So happy to comments or
questions, Jim?
Thanks, Neil. I think in the paper you said that about a quarter carry on with the trust. What happens to the others, and do we follow them in their journey after they've come through our program?
Yes, we do. So people go on to other roles, so actually, and higher education as well. So people do tend to go on to other areas. So it's definitely a stepping stone. Some of that, as you say, is in the trust, but then there's all these transferable skills to go and do other things, and the confidence, so it's a huge thing.
So
Follow up. It'd be really good to chart their progress as a cohort as they come through, so we can actually show that where they go after.
I'll take that back. Yeah.
Yeah. Can you hear me? Yeah. So mine is a comment as well. We talked a lot about patient experience, and we've seen patient experience referenced in the NHS plan. And I was just reflecting on something that was said then. To get true patient experience, the patient has to trust the person that they're sharing the information with. And I was really struck there by what one of the team said, that patients probably wouldn't have shared things with the team that they shared with Yolanda. And I think that's a key element. So really, it's something to think about when we're gathering patient experience data. Who's telling us this information and who isn't? And where they aren't, how can we deploy people who they trust to get that really, really special information? So that was a really valuable film to watch. Thank you.
Suzanne?
So I'm a huge supporter of the PEF scheme. I think that that the people who are on it have accomplished an enormous amount as individuals. And I would encourage you, if you have the opportunity, to go to any of the forums where they occasionally have been able to present their experience. It's extremely moving. And I won't breach anyone's confidentiality by sharing that at board, but it's extraordinary, the transformative impact that being a PEF can have on an individual who has used services. It's quite extraordinary. The thing that I wanted to acknowledge as well is that one of the reasons why this has been successful at Oxleas is that they have had really good support in the scheme. It's been very well run by the team that is leading it. Which is partly Jacqueline Core and partly people who work with her. But they've really committed themselves to ensuring that the facilitators are well supported. And I know that there's more than two, but there are definitely two people who have passed through the scheme who have then gone on to full-time permanent employment in the trust, doing very valuable and worthwhile jobs, to some extent using their lived experience, but also just having got to the point where they're able to do a fabulous job and are no longer our service users, but our colleagues.
Thank you. And I guess my question is, we have, this is an example of innovation. This is an example of innovation that have done it well because we've had the right people thinking about it. How do we spread the adoption of this innovation wider across the NHS? What are the barriers to doing that? What are the mechanisms by which we can use that? We can help spread this innovation to improve healthcare outside our immediate concern, but inside our more general concern.
I do agree, and I think the one thing we could get better at is describing how we support people, because we do it quite implicitly. It's a very Oxleas thing to do, but I think we need to look at it and sort of name it and describe it, because I think it's a very unique approach. People are really supported. There's a lot of sweating of small stuff that goes on behind the scenes. I think we need to describe that as a way of spreading it, because without that, as Suzanne was saying, it just nothing works. So that's our plan, is to get a bit less modest about that.
And I think that's really important as well, to describe that stuff that's implicit. So often when innovation spreads, people describe the piece of hardware or the piece of this that is transmitted. And it's that tacit information that people are bad at describing that often is what enables innovation, whether it's innovation like this or whether it's more technological innovation. It's all innovation. But actually, it's that tacit information that we don't know we know, that actually we somehow got to bottle and push out to help other people do it. Thank you very much, Neil. That was really interesting. I will now turn to Iffy for the board assurance framework update.
Thank you, Chair. So colleagues, I'm sure would have read the bundle, would have seen the board assurance framework, which hasn't changed since we last met. So the only change you would notice is the fact that there has been a revision of the in-year risk by the Business and Infrastructure Committee. We still have the same number of risks, 10 of them, 4 that are significant. And when you cast your eyes over those, you'll recognize that the rating remains quite relevant, 3 that are high and 3 that are moderate. I suspect that by the time we get to the next board review of these, things will change, not least in light of our earlier discussion about the 10-year health plan, what the implications are for us. But nothing really of significance, if I can put it that way, to draw the attention of the board with respect to the framework.
Thank you. Any comments or questions for Ife? We will look at this in more detail in this cycle of things. No. Okay, thank you. Okay, we move on to the chair's report. I was going to start off by congratulating, actually it says here Ife is an Oxleas executive team. I actually think it's important as well to congratulate all of our staff and all of the managers all the way through, because that's what's done it. But being included for the second time in the, I don't know why it's 26, slightly odd number, but 26 best places to work for very large organisations. I mean, a very great achievement, and one that's shared by people not only around the table, all of our staff, all of the managers, and everyone who contributes to that work. So well done. I think we should note that. I also will embarrass Ife, I think possibly for the last time, by name for the top 10 execs. I've been teasing him over the last few weeks around this one, but seriously, I think it does show something of his leadership, the genuine quality of his leadership, very human quality and rather understated sometimes, but actually something that as I am getting more and more networks, I've realised how the respect he's held in by people, both within the organisation but without the organisation. So thank you, Ife, for your leadership. I'm not listing all of the visits I'm doing, and I'm trying to, and I think I'm going to try and encourage people as well to do it with the board visits, to try and think about the meta levels, the learnings from the various visits. And I think the 2 visits I've come into mind as we've been talking about this, one of which has because it ties into the presentation that Neil led us on, which was that I visited with Azra the easy reading, where again we use people with learning difficulties in a very supportive manner to look at our leaflets and make differences. And I'll just comment on it that again, a little bit like we heard in that presentation, I saw some leaflets which I thought were pretty damn good, and then the team turned to it and they made them a lot better. And, you know, it was real value added. You could see the value add. It wasn't just doing it. And you also saw, again, as Neil said, the care that it took to enable that to happen. It just doesn't, it doesn't happen. That's one thing. The other thing I wanted to also do, because I think it's something that I think we need to start thinking about. And Ife and I have been having conversations about this for the last month on and off. We visited the perinatal unit, which looks at women around birth, and I'm not going to describe the visit, that will come in the board visits in the future, but the thing that really struck me was it's a really well functioning unit, but team that also functions really well in partnership with other teams across South London, works really well across South London, and that's partly because they are centrally commissioned by NHS England, and therefore there is a services framework. There's no disagreement about what the service should be. There can be differences about how the service is provided, but there is an agreement about what the service should be. And it's made me think and reflect that all too often in mental health and actually in physical community health, sometimes we have that agreement about what the service should be, but sometimes in actual fact, we don't. And I think that that's something probably as a sector we need to work better on, to think through what those services are. Excuse me, sorry. Other reflections. Sorry, my computer keeps turning off today. I put some other reflections I've done in my report. I think we are going to have to get used to working with ambiguity. I think we are going to have to continue thinking about how we work as with partners, and a lot of our effort and energy is spent at the moment in working with partners. And for some partners that's really easy, and for some partners it's actually quite hard work to work with them, and we need to work out how we keep our values, and I think that's continual discussion. I've had some meetings since I put this plan together. I had a meeting with Jim McKay I did a meeting with him around the 10-year plan. I'm not going to repeat a whole load of stuff that we've already talked about today, or we will read about during the on our WhatsApp messages during the lunch break. But I think that there are some things that, again, we've got to be careful about. There've been some messaging that's implicit messaging that's gone out, which he's quite clear isn't meant to go out, be read in the way it's been done. So, for example, there's the abolition of the Health Watch body. Now, he is very keen to say that that's not about killing the voice of the patient. That's about simplifying the landscape. Well, we need to make that happen, but that is actually, there is that one. There is also things like the closing of the Guardian's office. That doesn't mean that the freedom to speak up Guardian's role is gone, but the way in which that's managed will be changed. Well, again, I think we've got to decide very much what we want to do and what we think important. Personally, I think the freedom to speak up Guardian role is really key to what we want to do, and it's probably something that we'd want to do. But there are going to be freedoms. There are going to be more foundation trusts. He's going to open the route for foundation trusts. He is, for example, has said that there is no need for governors. Now, actually, from my point of view, I think governors add an immense amount. So we've just got to be very clear what we want out of this, and not actually necessarily get distracted by some of these headlines, or we've got to make them work in a way that we want to. I also think that one of the things that has been under-mentioned, but I think was mentioned is the concentration on patient experience, that there will need to be a director of patient experience on the board. This is something that I think is something that's very welcome to us, but something that we need to build on. I think the rest of it we will find out in the next few hours, or not, as the case may be. What else is there? I take the board effectiveness review you know about and is in the report. Happy to take any comments or questions at this stage. No, okay, I'll turn to Iffy for his report.
Thank you, Chair. So as I typically do, I'm going to assume my report is read, and I just want to highlight a few things. I was intending to highlight the 10-year health plan, but I wouldn't do that, because I think we've done that to death. So the ICB blueprint, we've talked about this previously, just to say that we are still in discussions with the ICB about what aspect of their role providers will take on. And you will have seen in Ian's report, they mentioned the link between that and neighborhoods, where in Andrew Bland's podcast, he was suggesting that he sees the potential for neighborhood centers when they're set up to take on the roles of ICB in years to come. So I think this is probably seen as a first phase, and there's probably going to be yet another phase of change. You will have seen in my report, and the link is in there, the NHS oversight framework has now been published. 28 metrics in there, 18 of those concern us as mental and community health provider. We have not yet officially received our segmentation, but I anticipate that will come in the next week or two. The plan, of course, is that in this financial year, ICBs will not be segmented, but they will be segmented from 26 to 27. Providers like ourselves will receive our segmentation, as I've said, shortly, but there will be an opportunity for the segmentation to be revised every quarter. And I think that that's really quite important. Many of us in mental health trust are concerned because there is the view that quite a number of trusts that are currently in the oversight framework arrangement at 1 or even 2 with the segmentation have gone down to 3 or 4. For the majority, it's about money, because if you're not right with your money, then you're not likely to be anything higher than segment 3. But we just need to see how that pans out. So there's a discussion going on in the mental health network about how we address this with NHS England. But there's also a view that many organizations, as the year progresses, when their money becomes tighter and they're not able to achieve what they've promised, may end up going from wherever they are down to 3 or 4. You may have seen the Health Service Journal has been stating that there's probably a gap of 1.2 billion that's emerging. I'll be surprised personally if by the end of the financial year it's just 1.2. I rather suspect that to be higher than that, but we'll see how that unfolds. The other thing I wanted to draw attention to is the interim ADHD task force report. I would really encourage board members to read it. I think it's this interim report gives an overview of ADHD, the challenges, etc., and the recognition that it's not a matter for just the NHS. This is something that involves many government departments, and to address it, we all need to work together. The task force was apparently set up because it was thought that the economic cost to the individual and the government is estimated at £17 billion. That's a lot of money. We run prison services, and we know that there are quite a number of young people, be it in a young offender service or even in adult services, who have this condition, and had they been addressed when they were younger, who knows, may have made a difference. I read a really interesting article of a review from Sweden in the last week that showed that when ADHD is narrowly defined, diagnosed, and treated, there are huge benefits. But as soon as you begin to broaden the definition, those benefits are lost. And I think that that's important, because this report seems to suggest that ADHD is under-recognized in the UK, under-diagnosed. And if you go by the prevalence that's published, I think we get about 10,000 referrals a year. It's suggesting that in Southeast London, when I say we, I don't mean Oxleas, across Southeast London, it suggests that there are probably 100,000 people in Southeast London with ADHD. Just imagine if they're all pitched up to be seen. I think Slam and ourselves would be overwhelmed. This is why this is really, really important.
So 10 out of 100,000 every year, and that gap presumably grows cumulatively over time. Okay.
Yes. So just based on prevalence, so 3 to 5% prevalence, you look at your population, it gives you an idea where you should be. So we're nowhere near those numbers. And I don't think, frankly, that we want to be anywhere close to 100,000 people seeking ADHD services across the lifespan. I think that will be very difficult to manage. And what I have done in here is to give some data about the weights for children and for adults. Did that in the interest of transparency, because I think it's useful. Because we always talked here about how much of a challenge it is. And I've also put in my report some of the work that's going on for children and adults, and Lorraine is here because she plays a crucial part in the adult services across South East London. So again, I think you'll make really interesting read. And then the final thing, of course, we have our Living Within Our Means program, which you'll hear more of. And that's all I wanted to draw attention to. Thank you.
Questions or comments for Iffy? Loudly, so you can keep my...
There's one question and one comment. The question was about the oversight framework and the metric, which was the annual change in the number of children accessing mental health services. And I'm wondering what they're trying to get at there. You know, if our annual change is, do we want to increase it or reduce it? So how are they going to judge what you find with that metric? The other comment was, I don't know whether other board members were present at the governor's meeting when Dr. Sadiq, who's the ADHD lead, presented his work. But I think we're extremely lucky to have him here. And I think South East London benefits from his leadership, and particularly in terms of his emphasis on finding pathways to treatment which are not wholly drug-based, but which are much more educational and enabling people to live with their condition.
So I really can't address the specifics of the annual change, but I think that's more about the proportion of people who are young people who are waiting to be seen. Simon and I were in communication last week, and one of the things we want to do is to make sure that we become absolutely clear about each of these metrics and what they mean for us. And I also want to try and bring data to this board in my paper about how we're doing against those metrics, because I think that they're going to become really quite important in terms of the way that we're judged or viewed as an organization.
Yeah, I mean, two things. I mean, just on that last point, we're going to have a conversation in a moment about timely care, and I think one of the things that I would like us to think about is how the timely care approach, which has proven really successful, I think, in some areas such as community health, could be brought to bear a bit more explicitly around both neurodevelopmental weights, but also children's mental health. So we can hopefully have a discussion about that in a moment. I just had a question, Iffy, about the Swedish data, and then linking that to what you were saying about prevalence in Southeast London. So is that prevalence in Southeast London based around a wider determinant of diagnosis than in Sweden? Because I think you've queued this up. This is the kind of key debate, I think. And I think linking it to what you said earlier, Azra, about what we can do and what we can't do, this feels like the kind of front line of that conversation, frankly. And it is something that we as a board need to get our heads around and kind of support our services to, and also the public to kind of think about.
So it's really quite interesting. So I was reflecting that when I was training, so it would have been around about, I think, 82, 83, I ran an ADHD clinic. It was me, my supervisor, a psychologist, and every patient we saw had a brain scan. And then today, it's 90 minutes in, out, and the diagnosis is made. And I don't know if over that period of time, the prevalence of ADHD has gone up, or that people are now, as society becomes more sophisticated, finding reasons for whatever challenges we have. I honestly don't know, And so the Swedish paper, I think, was directed at this notion that more people are now being diagnosed with ADHD. And if you compare the benefits of medicating them to those who were diagnosed some time ago, those benefits are lost because you have a larger cohort of people. And I worry that if we continue to go with the way we're going and continue to invest as much as people expect us to invest, where it's got to be a specialist team that sees people, makes a diagnosis, medicates, that the benefits to individuals will really reduce. Because there are people who, even if they have ADHD, don't need medication. There are people who just need to identify some of the things they can do differently and what supports they need to manage their lives, and I think that I hope that that's where the task force will land. So the suggestion in my paper that mental health support in schools, for example, might help teachers and parents to support children. I think that that's perhaps one way to go, rather than everybody queuing up a year, 2 years to be diagnosed to then get medication. We'll end up in a society where everywhere you turn there are pills. That worries me personally. I don't know if that answered your question, but that's where my head was going when I was thinking about this.
On that, and I understand there's work to be done, but if we have the potential of an unmet need of 90,000 people at any given year, do we have a view or an understanding yet of how many of those people would be ones which actually we don't want them seeking medication or support? Actually, it's fine that they're not coming here. They're fine with parental support. And how many of them are actually us failing to meet a real need because they're not getting the diagnosis and support that they need? Do we have a view on that or a sense of that?
So I don't have a sense of that. I only quoted 100,000 based on the prevalence rates that I read in the paper. But I think that that's the role of the task force, that this is not just about health. It's about at different time points on people's journeys or in their lives, making sure that there's awareness, there's support, there's early intervention, and any other form of support that people may need. And if you think about prisons, we do some work in prisons. So these are people, one isn't saying that it's entirely ADHD that's resulted in them ending up in prison, but where you identify people who have needs, and if those needs are sufficiently significant that you need to intervene, then I think we should. And again, I'm not sure that any society can actually touch base with everybody who's got a condition. We had this issue with dementia a few years ago, it's still there, where there's a prevalence of dementia, and we're required to make sure that we continue to identify people with dementia. I don't know that we'll ever have the resources to do that.
I think it is absolutely critical that we look at this in terms of other inequalities that those children might have. So if we look at, for example, socioeconomic, other factors of deprivation, because those are the ones who are likely to end up, and we have such a duty of care. So we need to be able to do that multi-agency, multi-sector working to be able to identify who those are, because quite often their families won't even have the means to be able to identify that there is a problem.
Agreed.
So I'm thinking this is a really important issue. It looks that the task force is going to report towards the end of this year in its final report. I'm sort of wondering whether this is an important issue in its own right, but it's also an important issue because I think it's actually lays bare some of the very interesting tensions that we have between what is a medical condition and what is normal variance, and what's on the spectrum and what's not, which is, I think, and also the interaction, as if he's raised, with prisons, where there are also some very particular issues about whether you can or you can't be tested once you are a prisoner or inside forensic services. And I'm wondering whether we have a board seminar on this towards the end of the year when this task force has been done, and maybe ask some of our experts in the trust to contribute towards this, so we have a common understanding, because I think a lot of people around this table will have a clinical understanding of what we're talking about. But I think if we developed a common understanding of that language and debated perhaps some of those ethical issues around what is a spectrum, what is a condition, what is a pathology, and what is just normal variance, which is really difficult conversations to have, I think would be a useful conversation. Is that good? Is that good? Thank you. Iffy, anything else for Iffy on this? Thank you very much. Okay, we're now moving into the trust strategy. Really pleased that Abby, Lorraine and Rachel are involved, and Sally, I think you're leading this off.
Yes, so I'll start the introduction. So as you know, we launched our strategy for 24-27 in September last year. We agreed that we would bring 6 monthly updates to the board. This one's a bit more detailed than we would plan to go in the future, but as we've got new members of the board and it's the first one, we've gone into a fair amount of detail. Since we've launched the strategy, there's been a huge amount of work that's taken place, particularly with service directorates, to look at actually taking the goals and then trying to change those into tangible actions for our staff working in those directorates, and also to develop the measures which you'll see in the dashboards, which are in the reading room part of the board pack. So I'm going to hand over to Abby first, who will talk about the priorities. We'll have a short discussion on the priorities, and then I'll finish up. So over to Abby.
Going to all talk first and then questions after. Okay. So thank you for the introduction, Sally. And for those of you who are not aware, I'm the SRO for Great Care. And what our aim is to provide good quality care, which is equitable, and for patients to have a good experience of the care and services we provide. That is our bottom line. That is what we're trying to do. And what we've done with the iteration this time around is learned from our 21 to 24 experience in terms of being able to tangibly measure what we've done and who has it made a difference to. And as a result of that, we've split the Great Care Priority into 3 programs, with kindness and compassion being the first one, patient-centered care the second one, and addressing and reducing health inequalities being the third one. And you will find out when Lorraine talks and when Rachel talks, all the 3 strategic priorities are interlinked in one way or the other, and we all recognize that, so we're all working together. So over the last 6 months, we've been trying to make sure that we've got a program of work that we can define and that can be measured. And what has come to the fore, and we've already discussed it today, is how we need to have much more robust patient experience data that we can use, because our consumers are our patients, and they need to be able to tell us whether we're delivering great care from their point of view, rather than us sort of saying, this is what the standard says, and if we give you that, we're delivering great care. So we've recognized that. So that's our weakest link, and we're going to be working much more on that. We're using questions from the staff survey, questions around compassion and kindness to measure what we're doing, as well as looking at things like NICE guidelines and other national guidelines. I think at the last strategic exec, we spoke about all the work we will be doing and are doing around reducing health inequalities. So I'm not going to go into that. So I'm happy to take any questions, because I think it may be easier for me to answer questions, but I'm going to hand over to Lorraine next, and I'll wait for questions at the end.
Thanks, Abby. So timely care, sorry. Timely care is in 2 strands. We've got the beds programme, which Ian leads on, and some of that update is within his performance report, and then zero delays, which I lead on, which is around waits for community teams. And people will remember in the last iteration of the strategy, we did a lot of work to make sure that people actually had an electronic waiting list on Rio, which sounds like an incredibly simple thing to have done, but was in fact incredibly complicated and took a really long time. But what we've now got is some really rich information that teams are able to use, and that's helped us to develop much more sophisticated dashboards. So we know that in the time that we've been working on this programme, demand across a number of services has continued to rise. That's been a real challenge for the programme, but also a challenge for those teams in how they look at that data and how they think we perceive that data, because it felt like for lots of teams they were failing. So we were monitoring waiting times, looking for improvement, putting in interventions, and actually waits in a number of areas were continuing to grow. what we've been able to do now is create much more sophisticated data, which shows teams whether or not they've increased the number of appointments, so that they've increased the number of people that have come off the waiting list alongside the waiting times, so that where you've got high demand, you can see that that's not impacted by an unproductive team. And that's really, I think, given teams a different appetite to do the work. They're much more motivated when they can see those two things together. So I think that's been a real achievement recently. And we introduced those dashboards last October, in October 24. And since then, 49% of the teams that are tracked have shown an improvement in waiting times. So we're getting there. There is still, as you'll imagine, a huge amount of room for improvement. We still have waits. We've talked about some of them today in relation to some of the longest waits across the trust, which relate to those neurodiversity waits. So there is still work. We've got the benefit of Jill Idle as the person leading on the quality work stream for Zero Delays, and she's started some targeted improvement work with a couple of teams where there are really complex issues that lead to those waits. And so one example of that is in community mental health in one of our ADAPT teams, where actually there is poor flow, inability to discharge patients, which has led to really high caseloads, which then impacts their ability to take people off the waiting list. And they recognise that there are risks involved with those waits that they need to address. And so actually the improvement work will look at discharge, but the end product of that will be an improved waiting time because they'll have the capacity to see more people. So there's some really nice work in a number of the directorates, and in adult community health, they've made some really good progress around some of their waits in their smaller teams, where perhaps the opportunity didn't always feel like it existed in the same way, but actually through quite small changes have made a real impact to waiting time. So some of that is in the pack, but that's probably all I was going to say for today. And like Abby, we're happy to take questions once we're finished. I think Rachel, over to you.
Yeah, so I'm here in my capacity of supporting Abby, Lorraine, Rachel, the other Rachel, and Sally to operationalise the strategy. And in Rachel's absence, just want to give a bit of an update on best place to work. So I think Abby alluded to it at the beginning, best place to work cuts across all the work areas. And as we have been talking more and more about it, we recognise that actually the environment that our staff work on is really important in helping to deliver great care and timely care. So we are really looking at how we look at targeted teams and how we build the cultural work into what we do. In terms of the kind of key deliverables of best place to work, one of the key focus areas is around our annual staff survey results and really looking at how we can year on year improve the staff survey results. I think what is clear is that we as a trust are doing extremely well overall in staff survey results. But what we do recognise is that if you drill deeper into the data, you might see pockets of challenges. And so what we've been particularly focusing on over the last 6 months is really understanding the data, creating dashboards and visual ways to look at heat areas and where we can support with interventions in particular. So that's been a key focus. Career development conversations has been highlighted as something that's really important for the organisation to retain staff. And so there's been a considerable amount of work looking at how we bring to life things that stop people from progressing or create barriers through our Smashing It's career development series, which I know a couple of the members of the board have been part of. These sessions have been really interactive and really unearthing issues such as imposter syndrome, hitting the glass ceiling, really kind of getting to the nubs of some of the issues that staff feel when they talk about career development. Alongside that, I know there's been a lot of work with Jane's team around the professional nurse advocates to create a career development framework that makes it really easy for many of our clinical staff to access support.
Oxleas. So many of you will be aware that over 3 years ago we launched Early Leaders Programme, which was focusing specifically on our early leaders. That contract came to an end last year, and we decided to do a bit of a deep diagnostic around what do we really need to create an environment where our leaders can flourish. And so over the last 3 months, we've commissioned a bit of a diagnostic. We've received the report this week, and so that's something we will be sharing with the exec around the outcomes to inform a revised approach to Oxleas as well. There's been a lot of work, which I think Neil can speak on quite well, around how we support staff who go through difficult HR processes through experience-based co-design. That work still continues with a particular focus more recently on performance management and having difficult conversations and how staff experience that. Alongside that, we've been looking at team development specifically and the cultural context. We have most recently partnered with an organisation called BRAP, who are specialists in cultural competencies, issues around race, and this builds on the BAFO 5-step challenge work that we're looking at. How do we create environments where teams are able to speak about difference more easily? I think the only thing I'd highlight is the dashboard we're now looking to develop, which looks at how we bring together our values. So we're kind, we're fair, we listen, we care, against our staff survey results, but then also how we look at that in very easily covering NHS impact domains and quality domains particularly as well. So there has been quite a lot of work going on in the last 6 months, but we recognise that there's still quite a bit more to do, and we're shaping that as we go along.
So there are 10 core commitments, and so details about those are in the pack. Some of those are much more defined programmes and plans, such as sustainability or the Living Within Our Means plan. And others are very much kind of underpinning other parts of the strategy. So, for example, how we're using our partnerships to support building fairer Oxleas services. So, you know, there's a lot of connections across elements of the strategy. And of course, now there's the National 10-year plan being published. We'll need to have a pause and look at our strategy in light of the 10-year plan. I mean, all indications at the moment are actually there's good alignment. You know, moving from hospital to community is something that we've been talking about for many years. But I think neighbourhood teams will offer us an opportunity to think about how we deliver and implement some of our strategy and the partnerships particularly that we will need to have in place to support that. So the next 6 months will have a big focus on taking that forward as well. I'll end there, and I know the people are wanting to ask questions.
Yes, so I had 2 questions. The first question was around the kind of intersection between patient experience and health inequalities. So absolutely brilliant work, really great to see the conditions being created for patients to feel comfortable and able to report their experience. I wondered if our next step after we understand our patient population is to understand which patients are not telling us about their experience, because I think that's really, really important for us to know going forward. So is that going to feature on that dashboard? And that was my first question to Abby. I'll just add another question, given that I've got the mic. That's sort of more broadly across all of the changes that we're wanting to see. It strikes me that there's something about culture change that needs to be there as well. So, for example, with partnership working, with the adoption of different digital tools, our staff and our partners have to have the motivation to want to do it. We know that they need capability, they need opportunity, but they also need motivation. So I wondered what we're doing to encourage or facilitate that motivation to adopt these changes that we need to see.
So in response to the first question, now that we've got our Power BI tools, it means that we can analyze our data much better. So looking at the kind of protected characteristics will give us an idea, especially when we start to marry our demographic data to what we're receiving. And then we will start to ask the questions, because we don't know what we don't know. We just have anecdote as to, I work in memory services, considering the large amount of Nepalese community that we have. I know they don't come to memory services because I don't see them, so I know they don't come, but we just need the data. So we do know, and we do have that data now, so we will be looking at that. And I want to answer a bit of your second question, which is about the culture, and that for me was the learning from the first 3 years of the strategy, that if you don't get the culture right, you will not be able to sustain any change, any strategic change. So for Great Care, the first program around kindness and compassion, the kindness to self is asking people to connect with their inner motivation. What makes you get up in the morning to come to work? Why do you want to do this? Why? And it may be contractual. You're doing it because you get paid, but if it is contractual, there's certain expectations that we have. So we're using that as a kind of program because we do know that you do need to have the culture where people want to flourish, and that will be part of any kind of strategic direction or trying to implement or sustain any strategic change. So we are looking at that as part of the different programs that we'll be doing.
I just add on the cultural aspect. I think part of it's also recognising the huge amount of change that we are expecting people to take on board and trying to involve people in that. So if you look at how we're taking forward the Living Within Our Means programme, we're trying to do that in a paced way that enables people to be involved and to take things in a considered way rather than sort of knee-jerk reactions, because these are difficult choices. They are, difficult things that we're asking people to do, but it's trying to use the strength that we've got as an organisation and engaging our workforce in particular to take everybody with us.
So I think you really hit a nerve when you talked about culture. There's nothing I can think of here that doesn't involve culture. And even as we've talked about what the announcements today will bring and the fact that neighborhoods, just think about us working in an integrated neighborhood arrangement. Integrated neighborhood arrangement and how different cultures of partners would differ, and how we need to make sure that if we are in that leadership role, we need to attend to all of that, So I think increasingly it's fair to say that people are recognizing that the NHS will only succeed if we tend to the culture of the NHS. But as it so happens, every organization, every provider has its own culture. It's about how we bring all of that together. So we're paying a lot of attention to that in Oxleas, but I don't think it's something that we're going to get to a point that says, it's done. It's something we need to keep tending to continuously.
I think this, in terms of the cultural aspect as well, there is something we had a good conversation about in Quality Committee about the patient voice and how we create a culture where that is front and centre of the experience. And just off the back of that, we have been talking with Jacqueline about how we create a PEF to support each of the work streams. So a PEF to support great care, a PEF to support timely care. So we're embedding that kind of focus of actually leading the work is not just us and the staff, but actually those that have lived experience. That is something that we're also exploring with Jacqueline and her team, how we co-create a culture where the patient voice is also imminently embedded in the culture as well.
On culture, I think there's a difference between a message which says we want to improve, we want to change to improve, versus we want to change because everything's terrible and you've done a bad job and the system is broken. And that's not our message, but it does feel sometimes like that's the external message. And are we seeing kind of do you have a sense of how that's landing with the staff? Because that actually makes people resistant to change. And what are we doing to sort of proactively try to kind of lift that mood?
I mean, there have been elements coming through with our shadow executive when we've talked about some of this, and this feeling of, I suppose, being done to rather than being in charge of your, own destiny. So it is something that we are aware of, and I think it is trying to, in our approach, trying to build on our successes and that engagement that we already have with staff and strengthen that, and just being mindful sometimes of the difficulties, but also some of the uncertainties. Some of the things around neighbourhood teams, we can't give people an exact blueprint of what it's going to look like because we don't know it yet. It's all part of being created. So sometimes just acknowledging that and enabling staff to feel that they are able to ask questions about it and not feel that they've not done their homework, then I think that's part of the approach.
There's also something about how you hold, contain and support staff within everything that's going on. So in some of the workshops that we ran with the directorates, there was a discussion about what's your audience and what message do you want your audience to have so that they're not worried about things they shouldn't be worried about, but are able to concentrate on things that they should. So that's that we just try to manage that so that we can support people. But as Sally said, you do need to acknowledge what people's concerns are and what the worries are, and then have a discussion around what are the joint solutions. And I think that's one thing that we are trying to and continuing to do, is that we don't have all the answers. The solutions are going to be done jointly, they're going to be developed jointly, and most importantly, implemented jointly with iterations as we go along. And it's just how we manage that together.
Thank you. And I think sort of key to that is also us as leaders and managers making sure we walk the walk on that one and actually allow people to innovate under, under a framework of responsibility and accountability, but actually which gives them the freedom to make mistakes sometimes. And that's, I think we've got that in it, but sometimes, again, as somebody was saying, the external environment doesn't always lend itself to that sort, and we've got to sometimes give our staff the air cover to do that. Jim.
Thanks. I had a couple of questions, but just on that last point, part of it might be about accepting risk as well. I mean, as we innovate, there will be risks, things will go wrong. And so we have to have a culture in which we accept that sometimes things won't go quite right, but the risks are there and it's worth doing. My two questions were on timely care, if that's okay. One for Ian and one for Lorraine. In terms of the timely care program, obviously the reduction in variation across the wards is quite a knotty problem. So where are we with that? And can you see progress in that? That's question number one. Question number two, Lorraine, is again similarly around demand and capacity. That's quite, again, a knotty problem with the data side of things. Are we progressing with those? And finally, one last question. Commitment number 7 was around, I think, innovation. And within the commitment itself, I didn't actually see how we're actually going to adopt the innovation. I think you can identify, and I think comes to the earlier point we had, is how do we scale what we do? And I think there's maybe a lack of how are we going to adopt it going forward.
I mean, in terms of the bed recovery program, what you've described is a kind of key part of it. I think progress is steady, but perhaps could be quicker. I mean, my feeling is that there isn't anything that we're not doing that we should be. So we're doing all the right things. But that variation that we're trying to focus on, there's such a kind of cultural determination of it that it takes perhaps longer than it should. I think some of the things we've done recently, which will really step it up, is to do lots of proactive engagement with kind of senior clinical leadership. So Abby and others have been doing a piece of work to engage the consultant group. And I think that is really important because they have a huge influence, I think, around the work of a ward and a multidisciplinary team. We talk about multidisciplinary working, but of course, people look to the kind of medical leadership. So I think that is a kind of key thing. The measure is that overall average length of stay is coming down. What we'll be looking at in the kind of upcoming bed recovery program is the extent to which the kind of we're closing the gap on the variation. So it's still there, it's coming down. We're just trying to accelerate the pace because we're up against the deadline of October. So yeah, that's very much in people's minds.
In terms of the demand and capacity, there is now a data set that teams can look at. I think, okay, sorry, is that better? There's a data set that people can look at. What we're having to do at the moment is create a more, again, a bit like we did with the weights, a more sophisticated version. It shows that there is an opportunity across most teams to improve productivity, if that's the language we want to use. But what it doesn't do at the moment is reflect individual job plans. It just reflects whole time equivalents in a team. And so teams are rightly raising that that's not a fair reflection of their capacity. So there's a little bit more work to do to make that more sophisticated and therefore give teams a better opportunity to work to it. But we've taken as a subset a few teams where we've done much more kind of a deep dive into demand and capacity, and that's revealed a really mixed range of things. So there's definitely teams where there just isn't the capacity to meet demand, even if teams were more productive than we think is reasonable for them to be. And there are teams, when you do that deep dive, where the opportunity is actually quite large, and it's about trying to understand why there is that opportunity, and is it that there is room for people to be doing more, or with one team that we've looked at, we're asking them to do quite a lot of things that we might have to stop because it's getting in the way of them seeing patients, and we're measuring this on patient contact. And actually what we're finding is they're doing lots of really good stuff, a lot of which involves attending meetings and being champions and involved in wider developmental work, but we might need to pull some of that back and convert that time back to patient-facing time.
And just on the innovation aspect, I think you're absolutely right. And actually, we're doing a piece of work with a person that's on the Aspiring Chief Executives programme to look at exactly that, about how can we make sure that we're actually using innovation to inform our practice, and the resources that there are around us in sort of innovation and research, that we're pulling that information in and connecting in as strongly as possible, because it's all about sort of networking and actually translating it. So trying to make that connection better, so that's in progress.
Just wanted to make a couple of observations, if I may. So the point Lorraine just made there about demand and capacity and productivity, that's not going to go away, not just for Oxleas, but across the NHS. And in particular, this notion that it's about contacts divided by whole time equivalents. I mean, that's a national measure that's going to be used for us in community and mental health, no matter how crude it is. And so also attending to it to really refine and get a good sense of what our whole time equivalents are doing, and whether what they're doing is the right thing that really addresses ultimately patient care will be important. My second observation, going back to how we started this morning, 10-year plan going forward, is that as I reflect on our strategic goals and the underpinning, the 10 underpinning things that are in the paper, it's clear to me that we're on the right track. Frankly, irrespective of what the announcement today says, if we continue to do what we're doing and continue to really, really hone in on how this is making a difference to the people we care for, making sure we're using our resources as best as we can, we'll be fine. I feel fairly I feel quite confident about that. And in some ways, it's kind of reassuring just listening to the discussion we've had and revisiting the papers we've got in front of us.
Thank you, Jim. One last point, then I think we can.
Last comment, really. I really appreciate the paper that the exec team wrote. It was really good, very clear, and I think that's an excellent sort of disposition of what we're doing.
Thank you. I think we're therefore agreed. I don't think we're meant to. We're approving this. I think we're noting this, but we're noting this with gratitude and thinking that this is the right direction. It's probably a larger paper, and then, as Sally said at the beginning, then we will routinely visit, but at this moment in time, as it's being worked out, it's appropriate for us to be seeing this level of detail going forward. Abby.
Can I just make one last plug for the kindness and compassion workshops for the non-executive directors to join one of those that are there? Because as Andrew said, we have to walk the walk as well as talk the talk.
I'm booked into one next week, I think. That's good. So yes, hopefully we're all booked into different ones, because then we can all have different experiences. That's all. I'm not sure. Okay, I'm going to suggest that we're an hour and a half in, perhaps a little less through the agenda, but I think that was a really helpful discussion, so I'm not worried about that. I'm going to suggest we have our break now, because I think the energy will otherwise drop a little bit. So shall we would 10 minutes be enough for coffee and a leg stretch? So we'll meet again at 22, and for those who are online, we'll meet again at 22. Thank you very much, everybody. I think it's 11:45, and we'll try and get through part one perhaps in the next hour. We're going to now do the response to the independent mental health homicide review. Abby, you're going to kick off.
Thank you very much, Andrew. So people are aware of the events that occurred in Nottingham in June 2023, so 2 years now, and the reports that have come out following then. So there was an initial report by the CQC in August of 2024 with recommendations, after which we were asked by our ICB to review our services. And then there was another report commissioned by NHS England, which came out February 2025, and which was done by Themis, which also came out with some recommendations. So what we were planning to do today, or Lorraine's planning to do, and I will just chip in, is to talk the board through what we have done so far in terms of the actions in Oxleas. We had initially been told that there would be national guidelines that would be coming out, but these are not likely to come out till October this year, if we're lucky. I have seen a draft and have made some comments around the draft, so we don't expect the final document till 2025, but we've already started the work, and I don't think there'll be much deviation from that. So I'm going to hand over to Lorraine.
Thanks, Abby. So as Abby said, we've been working alongside colleagues in SLAM and at the ICB to think about the review that we did of our services and the resulting actions. You can see in the pack, this is our local action plan, and these actions will form part of a broader South East London action plan that the ICB are in the process of pulling together, and that combined South East London action plan will be submitted to NHS England by the 3rd of September. So we've had the opportunity to think about whether or not there is any cross-organisation learning with SLAM and any additional gaps that might exist. We've added, therefore, to this action plan, so we had a number of actions as a result of the initial CQC report. We then added to it once we had received the Themis report, and we've added to it since we've done the work alongside SLAM and the ICB. There is a further meeting at the end of July. The template for NHS England changed 2 weeks ago. And so Abby and I are meeting alongside SLAM and ICB colleagues at the end of, actually, I think it's probably the first week in August now, to see whether or not there's any additional actions that are required for us. But we think that we've probably covered all of the gaps that were identified in our services. So unless there's anything new, we're not anticipating it will change very much. And you can see from the action plan in the pack that in terms of the range of actions that we identified locally, a number of those are already completed. And importantly, for community services, we're in the process of a big redesign of our psychosis pathway. That wasn't strictly as a result of this work. We've been reviewing all of our pathways anyway, which was a commitment that we made when the directorates were restructured to kind of work our way around. But of course, it has given us a very different kind of perspective and an optic through which to do that work. So there's a number of actions that are sitting alongside that programme of work. We've done that in close collaboration with staff. So we run listening events around psychosis for our staff, which have been well attended. There's been really good engagement and very positive engagement. I was almost a little bit surprised at just how amazingly staff have contributed to the redesign and just the kind of their perspectives on these actions. So that's felt really positive, and that work will deliver a new model by September, which we'll then implement in the new calendar year. So there's a real opportunity for us, I think, to create something that looks quite different, but that takes these actions and all of the good things that we know exist, certainly in teams like EI, and translate those for a much wider population of patients. So I wasn't particularly going to talk through each of the actions. I'm assuming that people have had the opportunity to read it. If that has generated any questions, then obviously we can kind of think about that, and I'm happy to answer in more detail, but I'll probably otherwise stop there.
Jim?
Thanks, Lorraine. I've got a couple of questions, really. Thanks for a really good paper again. In terms of the care team approach, two questions. First is, how does that differ from our original approach? So what's that difference? Secondly, and if this is a really good approach, can you then extend that beyond this team to other teams, and have you got plans to do that?
Yeah, so care teams was something that we introduced because we recognised that we weren't always meeting our own standards in terms of contact. And that was because of the really high caseloads that exist. So we introduced band 4 mental health advisors or senior support workers. They're slightly different labels because we use Mind. So we're working in partnership with Mind to deliver care teams in Bromley, and we deliver it internally in the other 2 boroughs. And it's done 3 things. It's increased contacts for patients because there's a nurse, a social worker, and 2 band 4s that have a combined kind of caseload. It allows specific interventions to be delivered from the nurse and the social worker that require a clinician, but a lot of the other work can be done by those band 4s. Patients have really liked it because when typically previously, if care coordinators were on leave, planned or otherwise, they wouldn't know who to contact in the team. They would feel like there wasn't anybody that really knew their care plan, whereas now there are 4 people, and so they feel much more sort of held by the team, and it's been very positive. So the plan absolutely is to roll that out. The discussions at the moment, because a lot of the Nottinghamshire review focused on whether we need assertive outreach teams still. I think there has been, we haven't gone as far nationally as saying that they should be reintroduced because it would be very expensive. But there is something about whether we can use care teams as a way of, for that particular population that we identified as being in scope, whether that's the right approach for that entire population. And that's what we're looking at as part of the redesign.
Can I just ask on this? I mean, it looks like a very sensible and really positive thing. How in 4 years' time will we know that it's still working? What will we do to do that?
I think we're probably relying on a number of the mechanisms that we've got already, but with new metrics. So we've got 4 focuses in the work that we're doing. One is around the data around referrals management, which will tell us, and discharges. So a key component of the work is to ensure flow. So we'll measure that. We've got a big arm of work around patient outcomes and experience. So we're going to have specific new metrics that relate to that. And I think in terms of workforce, we want a workforce where we can see better retention. It's one of the areas where we've seen quite poor retention and quite high vacancy factors, turnover. So we want a workforce model that is more stable, more diverse, and has better retention.
Thank you. I found this a really useful report, and I particularly valued those points at which you said we've gone back and checked, and we'll check whether or not the things that we initially introduced are correct. The thing that I was wondering about, though, is around the family engagement piece, and I can see that the family involvement in psychosis approach, is going to embed that, but there wasn't much about family engagement in the action plan. And I guess there's a sort of connection here with the strategic summary that we were given around the need to ensure that the triangle of care is working effectively. And I'd value your comment on that, but I also, when we had a discussion about Martha's rule and the introduction of it in the acute trusts, we also queried whether it's something that we would want to be embracing within mental health. My understanding is that there are some providers who are engaged with NHS England in thinking about introducing Martha's rule in other contexts, which I think should probably include mental health. So I'm wondering whether or not that's something that we're engaged in, whether it's something we would like to be engaged in, and whether it's something that, as when you referred to wider populations than just psychosis, whether it's something that we can take the opportunity to look at now.
Thanks. The family engagement work is absolutely critical to the success of this pathway because is it working? Okay. We can absolutely look to see whether or not we've made that clear enough in this plan, because it perhaps isn't, if that's what you've picked up. We've done some work with families recently to ask them what that should look like, and interestingly it shows that we probably haven't got right things that we hoped we had by now. So what they want is some quite basic things, information. They want people to listen. They understand all the issues around confidentiality. We're not telling them any of this, they're telling us that they understand that, and it feels like we haven't made enough progress in supporting staff to navigate some of that. We've put a lot of time and effort into it, but it hasn't somehow still landed. So there's a real renewed focus on that. And we've worked with Julie recently around some simulation work, which I think sounds like it could be a real kind of supportive strand to that work. But I think also we've got some families now that are going to support conversations with teams as part of the redesign. It will be much more powerful than it coming from us. So the family intervention, the formal work, I guess, is one part of it, but there's a much bigger programme of work about how it's back to culture, isn't it? How we shift the culture that enables staff to feel that that is just a natural component of their everyday interactions with people. Martha's rule, we haven't had very much discussion about, Suzanne, if I'm honest, but definitely something I'd be interested in exploring.
If we have any capacity, given all of the challenges that we have, I think it would be great if we could engage with the national, in that small group that are meeting nationally to see how it can be introduced in other kinds of trusts, because I think it's interesting in the community context as well, not just mental health.
Thank you. Any other questions or comments? Are we assured then, and this is to note, but are we assured that the Trust has taken appropriate actions in light of the events, and that we support the moves that the Trust has taken? Abby?
We will have a discussion with Sally as to when to bring it back to the board, considering that later on in the year there will be allegedly some guidance around how we should, because there's something you said earlier about a model for mental health, for community mental health, which is something we've been asking for a long time. It's the thing is that we don't have the research that underpins it. So we have for early intervention and for perinatal, but for the kind of heterogeneous community mental health, we don't have what good looks like. So we're all trying to find out what good looks like. So, but we will have the discussion as to when we bring it back to the board.
Okay, thank you. So we will see this again when we sort of map it against the national recommendations at that stage. But we are supportive of where we're at the moment for what we're doing. Thank you, and thank you for your work on that. There's a lot of work on that one, but it also looks like it's work that's going to actually improve patient care and support, and as well as keeping people safe is important. Thank you. Ian, the operational report.
Thank you, Chair. So in the operational report, you'll see that I've highlighted two cross-cutting issues. One is the development of neighbourhood working, and I'm conscious that we're going to have a further conversation about that in part 2 of the meeting. But really it's there just to give colleagues a sense of how things are progressing in each of the 3 boroughs around the development of the integrator role. The second thing I've highlighted is, and I've reported on previously earlier in the year, is the work that's being funded through the is in response to the review from the Better Care Fund of the Greenwich and Bexley system. And this is with the particular focus on how we improve discharge at Queen Elizabeth Hospital. And essentially what it is trying to do is to move away from the kind of annual focus that the system has on discharge through things like Super March, to having a kind of super every month of the year, essentially. But I may have said this before, it feels tangibly different this time, as in we're getting the right people across the different organisations to speak on a regular basis. We're putting structures in place, and it mentions in the report the transfer of care hub to try and knit all of this together. So there's a real kind of optimism, I think, around this work, and it of course really improves relationships day to day between the 2 local authorities, ourselves and Lewisham and Greenwich Trust. So really interesting ongoing pieces of work with that. And then you've also got highlights from each of the directorates. The detail is in the kind of reading room. The things I wanted to highlight in particular are the success of the tender for the liaison and diversion and male mental health treatment programme, which was an SLP forensic bid, but also disappointment that we have learned that we were unsuccessful for the Greenwich MSK tender. We're still trying to find out the details of why we weren't successful. At the moment, we won't be told until the standstill period begins in September, but we are asking Greenwich if we could have earlier feedback just to understand why they came to that decision, and also whether we feel on the back of that it is something that we wish to challenge. And I think that's probably all I wanted to kind of highlight, but happy to take questions.
Thank you, Ian, and I think real congratulations on the joint bid for the liaison diversion male mental health. That's really good news, and it's good that it's an SLP one. The other one was disappointing, especially again as it was a collaboration with secondary care and primary care and us as well. So that's very, because that's the way that we should be working together. So I think that is very disappointing, but we'll have to see what the feedback is before we take anything further, as you say. Any questions for Ian or comments for Ian? Welcome, Martin. I see you on screen. You may have been there for a while, but I see you now.
Thank you, and apologies for being late.
We knew that would be the case. Okay, thank you, Ian, for that report. In that case, we'll move on to non-executive directors' reports, and we structured this around. We'll structure this around the board visits, but in a way they're not. The reports on the board visits are written, so it's a chance for non-exec directors to say something that they've gleaned either through the board visits or elsewhere. But we'll take them as read. So I'll just go around the table, starting myself in a clockwise manner around the non-execs. I've already made a chair's report, but I have done there are 2 reports. I've done more that aren't yet through, but I've done 2 reports on board visits. Total of 4 prisons: Elmsley and Swailside on Sheppey, and Portland and Verne on the Isle of Portland. Again, the reports are as read. I'm happy to talk about them. I think that my overall learnings from them is in both of the visits. We visited one prison where the staff were very positive and happy and stable, and they often felt close to Oxleas. In the other prison, there'd been a lot of change, or there was tension in the prison, and one of the complaints staff there was Oxleas was a very long way away, and that's real. That's what they were feeling. So I'm not disagreeing with what they were feeling, but I just note that when people are, it means to me that when staff are under strain or under pressure for whatever reason, Oxleas can suddenly seem very far away and they don't feel part of it. When everything's going well, they feel part of it. So I think we've just got to think about how we do that, how we support people when they're under tension. It just was very obvious to me with 2 prisons. But I think the rest of the other thing I would like to highlight, actually, there's one piece of innovation I would like to highlight. That was on Sheppey, the use of the smart work stream, which is effectively a hospital at home if you're in prison, and the improvement that can make for care of patients, and reducing the need of conveyance from the prison to hospitals, because they can prisoners can be supported in the prison. Really good example, I think, of innovation. Also a really good example of why you need to talk to the innovation people early, because some of the innovation was delayed by a number of months because technical issues weren't discussed early enough in the process, which if they had been discussed early enough could have been smoothed over and dealt with. So I think it's just an example of good practice, but also ways in which people could do things better by asking the ICT people earlier what needs to be done. Alice, do you want to comment on that?
Yeah, I just want to come in on that point. We are now the first trust in the country to work with the MOJ to gain access to prison Wi-Fi. So that will now support that pilot, and we're hoping to be able to roll that out elsewhere as well.
So it's really good. It's a really good piece of work, I think. Thank you. Okay, going clockwise. Manisa.
Sure. I don't have a paper, but I joined Ian on the visit to the new Wandsworth Prison Health Centre, and I will say I was surprised by what a difference a building makes. Right? It's still in the same prison. I think there are probably a lot of the same challenges in terms of staffing and continue to exist, but just a nice room. It really changes the atmosphere of the place. So I think it's great that we've been able to get that off the ground.
Thank you. Sophie?
Yeah, thank you. I've got one visit in here, and I'm aware that I owe 2 reports, so they'll be coming next time. So I went to Shrewsbury and Avery wards with Ian and Rachel. And the theme, which is sort of comes through on all the acute and crisis, really is on admissions. And it's interesting to see that that's partly reflected in the staffing, which was picked up in the people committee. So staff feeling that some admissions are inappropriate, that the level of acuity is too high. That's what they told us. And they feel that that can then impact on their security and how safe they feel. So that was something interesting to note. We also discussed discharge, and again, looking at sort of the system-wide issues that impact particularly housing. So staff not wanting to discharge patients because they didn't have any housing to go to. And again, I know that that's a really common theme, and how do we work with that? And finally, about activity on the wards. So everywhere we go, we see that OT activity is really, really valued, but sometimes it's difficult to put into place. So those are the main reflections, really. And as I said, they kind of mirror what we see right across acute and crisis.
Yeah.
So I've been visiting adult community physical health in the last round of visits, about to move on to different directorate, and not very many of the reports have come in. But one of the things I did want to reflect on, which I think has come across as being a theme, is that the staff survey is very much done at a point in time. It's a snapshot in time, and that sometimes what you sense in a team is their culture isn't necessarily what shows up in the staff survey. I think there's a bit of a gap, really, and that's partly because the staff survey is one point in time, and people respond to some extent as they feel on the day. But I think also it raises a question for me about how we gather different angles, perspectives on what our staff are experiencing, and that the staff survey isn't a single point of truth.
Thank you. And I think we have to triangulate. Obviously, we might hear a bit from Simon in a moment. Martin, I'll return to you at the end, if that's okay, just because it seems vaguely logical. Jim?
I don't have any reports this time around. I do O2. But I did attend the Cavendish Square group with Alison about innovation, and that was specifically on the analog to digital transformation. So it's quite interesting to see what other trusts are doing within the patch in London. And there were a number of talks there, and I think the best was from the strategy director from London. Yeah, so that I think things are coming our way. The technology piece is coming together. From my point of view, the NHS is really far behind, and we really need to catch up, basically.
Thank you. Nina?
So I went to the special school service with Abby, Lisa, and Sabitha. It was a very strong, cohesive team. The one area of feedback that they had was because they are based in a school in Plumstead, they can feel isolated from the rest of the trust, and they would like more visibility of the trust senior management team and the directorate senior management team. It was a very humbling insight into the quality of life enhancing support that this team provides to children who have very complex physical medical conditions and significant learning difficulties. And it was really interesting to hear and to witness how deeply embedded they are within the school and how closely they work with families and with other disciplinary teams to be able to deliver what they do. Really inspiring visit.
Thank you. Jim wants to comment.
In terms of the outcomes, I mean, it's really difficult to answer this question, but if they weren't there, what would that look like for the families? Yeah.
I don't know whether Abby can come in on how we measure the outcomes.
I suppose the outcomes can be measured across different parts of the system. So whether there would have been an increase in social care need, whether there'll be an increase on the schools and the educational system in terms of, because they work a lot with the teachers. So if you're not able to do the kind of behavioural programme with the teachers, that may have meant extra staff coming in to support the teachers. And then I suppose it's satisfaction from the parents of the children as well, in being able to have their children in school, giving them respite because their children can be managed in school.
Thank you. Martin, I know you haven't got any board visits. Have any comments you wish to make from your observations as a NED?
Yeah, so thank you. I guess I'm visitor at large, aren't I? I've got no particular service directorate to support, but I have had over the past few weeks a number of visits. Two things to bring out: one positive, one for thought. The one for thought is everyone I've met is really tied into our strategic intent and our values and our behaviours, but they all pick up different parts of what is a very complex picture. And at the grassroots, sometimes I think we, at sort of service delivery level, there's a point at which people have to pick or choose between a number of the different corporate initiatives that we pass down for very good reason. It's just a reflection. It isn't to say it's wrong or right. It's just a reflection. I think we need to think about the weight of expectation on frontline staff, especially as we expect them to be more clinically engaged and working at the top of their license. The positive, always a positive when you go and visit places, but the one I would call out was I visited the Learning Disability Service annual sports day at Welling Sports Ground, which was both wonderful weather but a fabulous morning. Everyone really enjoyed it. There were hundreds and hundreds of families and service users there, and staff and service user alike had a great morning, and that was just for the soul uplifting.
I attended it last year, and it was a great morning actually. So thank you, Azza.
Just to say, I had 3 visits, which we were supposed to be going on with Steve, but once he left, we haven't had an head basically come in. So if I can just summarise, they were early intervention in Bexley, the Bromley Adapt team, and the Greenwich Time to Talk team. I'm going to say the former is a boundaried service, i.e. there's a gateway in order to be able to access it, whereas the others are a bit more kind of free-flowing in terms of the flow of patients coming through. All 3 services had issues with demand and capacity, which reflects an earlier conversation that we had. And I think there was a reflection in all 3 meetings about some of those capacity issues were linked to historic commissioning decisions, but what that is resulting in is a variable access depending on whereabouts we have got our Oxleas, Bromley, Bexley and Greenwich population based on historic factors rather than actually having equity of service across the piece. And I think that is something that we need to address with commissioners, and we just need to keep sight of that as we move into integrated care teams. We had quite a long discussion with that in each of the 3 areas because there were concerns about what that looked like across the 3 boroughs for those same services. The other area was around, everybody was very excited about the ambient voice technology. Virtually everybody that we spoke to said, we want to be top of that, top of the list for being able to pilot. So I think there's a real appetite for that. So some of the culture issues that we've talked around, we may need to address that as we then flow through into it. But certainly the appetite for that particular innovation is very, very strong. I wanted to just call out the Greenwich Time to Talk excellent work that they did with reaching out to the communities, particularly the Nepalese community. There was something about our interpreting services and how responsive that they are that I'm currently taking up with the procurement team. That was broadly the themes.
Thank you, Aswa. Abby.
So there are 2 visits in the pack, which Nina was not able to join us for. So one was to the children and young people's home treatment team, and we got there on the day they were officially launching the team. So it's a new team which provides an alternative to admissions for young people. They had been with the trust for 6 months, so they had had the opportunity to bond as a team before they started taking on patients, and they were very appreciative of that. And we had a mix of staff from both in and out of the trust, and those who had just come into the trust were very complimentary of the induction they had. And then the other service I visited with Jenny and Sabitha was the cash team at Market Street. And they were really buzzing around the Women and Girls Hub, which they had just developed. And the day we visited, they had also been out to the community to visit the Bengali women's community. And they were quite surprised as to the level of need and the fact that that community did not know about any of their services. So they were talking about how this can be incorporated into their job plan, because by going out, that had taken, it was a consultant that went out, it'd taken half of a day, which she would have used to run a clinic, but she felt that was much more valuable. And it made me think about things like innovation. So they're doing that. Older people are doing it with the Nepalese community, and it's how we bring all that together so that we can scale up.
Thank you. I think that's a really important consideration there. Okay. Anything else about those visits? Thank you for the visits, which I think are really helpful, but also thank you for your reports and the summaries of them. I think it was good to do it in the way we're doing it. Okay, we now welcome Simon. Thank you, Simon, for coming, and our Freedom to Speak Up Guardian annual report.
I have to say, I'm impressed with the timing this year, because I literally walked in and you're on my section, so I'm really impressed you've kept up to date. And I've remembered my hearing aid this year, so hopefully I'll be able to hear you all, actually, so that will be good. So yes, thank you. As usual, the annual board report, which I'm assuming you've all read. A bit closer. Yeah, okay, a bit closer. So as usual, I'd just like to highlight a couple of the executive points that I've made and expand on them, and then I'll be happy to answer any questions that anybody has. So this year, of course, we had 92 concerns raised. This is actually the most significant increase in concerns raised to the Guardian Service since we started working in the Trust in 2019. Percentage-wise, that actually works out as a 77% increase in concerns. Now, I know there are boards, because some of my other colleagues have had these sort of conversations where boards sort of start hanging their heads in the air and going, oh my God, why have we got so many concerns? It's not always necessarily a bad thing. In fact, within Oxleas, I think it's a good thing, because I think there's numerous elements behind it. And also because the concerns are sort of pretty much evenly spread across the directorates, there's no systemic issues that have come up on those things. What it is more is that more and more people are feeling confident to speak up and feeling that they can use the service. The introduction of the new monthly one-to-one booking team system, which I brought into effect back in October of last year, has had a massive impact. I give 4 days a month over and 4 slots a day for that, which is sort of about 14 slots. They get booked through the whole month. Staff say they found it much, much easier to be able to raise concerns that way because they can plan when they're going to talk. I think that's definitely fed into the increase in concerns. But I also think this is my 3rd year now that I'm finally embedding myself slightly in the Trust. People actually know who I am and what I do, so they're feeling more comfortable coming to me. So that is really important, that visibility is increasing. The top 3 themes for the year were management issues, systems and process, and behaviour and relationships. They were exactly the same issues as last year and the same number of issues as well. Management issues accounted for 54% of cases. That's actually a 10% increase on last year. However, some of the themes and concerns around management issues were slightly different this year, and they are cause for me for concern. We're seeing a big increase in managers contacting the Guardian Service for independent support, raising their reluctance to speak up to their managers about raising concerns. That's something new. I've not come across that in the previous 3 years. Also, staff have been expressing frustration that managers seem to lack skills in conflict resolution, and there's some reluctance from managers to get involved for fear of not making a mistake. I think that feeds into the same narrative of managers raising concerns where they don't feel comfortable raising issues with their senior management. The increasing staff expressing that their managers seem reluctant to take action, and managers themselves outlining their own fears for speaking up to senior management, is a concern, and particularly I think within the framework of speaking up. Because if we're encouraging staff to speak up and the staff are speaking up more, but then we have managers or middle managers who are afraid to speak up to their managers, that's a bit of an issue. It's not my job to fix it. It's my job to highlight it. And I did make a couple of recommendations, potential management support recommendations in my summary, which hopefully the board will take into consideration. The two red concerns, which I know everyone's always concerned about, the two red concerns, they are coming to their final element. They have had their reports from the trust. The two GPs in general are not particularly happy with the outcome, but there are senior meetings being held to address that in the future. Job groups. The 4 job groups, most common were admin and clerical, followed by nursing, professional technical, and allied health professionals. It has been pointed out to me, and I have to say that my knowledge of data analytics, you could literally fit onto a pinhead. So I'm pleased it's been pointed out to me because I know nothing about it. But it's been pointed out that the job group data can possibly be a little misleading. Considering the size of the different job groups that vary significantly, the percentages of the concerns by population of the workforce, until I've had to write this down because I don't know what my data analyst people tell me, is going to be more future. So I've spoken to Rachel and I've spoken to Debbie Clifford. They're going to be supplying me with more accurate workforce figures. So in the future, not me, but my data analytics team at the Guardian service will be able to make sure that that's broken down much better for people so they can understand that. Directorate-wise, it was pretty evenly spread this year. Adult community physical health had 22 concerns. Mental health had 22, physical had 17, offender had 17, young people had 16. With a relatively equal spread of the concerns raised across the top 4 directorates, that's not the data that concerns me. To be honest, the data that concerns me is the directorates with the systematically low level of concerns, such as acute and crisis. I only had 6 concerns. Now, that is significantly different to all the other concerns. With that in mind, I've had some really good meetings with the Associate Director, Paul Benyon, and we've been working quite closely to ensure that we basically try and increase the visibility within acute and crisis. We're hoping that that's going to affect it. I've had lots of visits over the last few weeks, visiting the wards and making sure this time, rather than just popping in and seeing 2 people, that I'm invited to their business meetings so that I get to see more people. That work is ongoing, as it is with forensics as well. So hopefully that will increase that. The last thing I'd like to highlight is obviously from the 1st of April, we added sexual misconduct into the themes that we record within the trust. The introduction of sexual misconduct under the theme, I think it's really important that we've added it to the reporting data because it's an important step to ensure that staff are fully aware of all the options and obviously will help with the board and help with the trust to understand what's happening in that area as well. So those are the things I wanted to highlight. I'm more than happy, as per usual, to answer any questions or discuss any of the recommendations or comments that I made.
Thank you. Nina, is there something you wish to say with the Ned?
Maybe a couple of quick things. The first is that we welcome the increase in the number of contacts. We have for several years known that our level has been lower than other trusts, and so we've seen it as a positive to witness that uplift, and it's very much testament to the efforts of Simon to get out there and really increase visibility. I think the new piece of information that is cause for concern, as Simon has highlighted, is the kind of emerging theme about managers and middle managers, and there is a programme of work. Is Rachel still with us? No, there is a programme of work as part of the people strategy. There has been for some time, focused around Oxleas and around manager capability. But I do wonder the extent to which, and you will see later on in the report from the People Committee, that we are seeing an increase in sickness, absence as a result of stress, as a result of anxiety, as a result of those sorts of things. So I do think that, and we have another session for the non-execs, Muniza and Jim and Martin, forgive me, in August, to look through some of what sits behind this and make sure that the measures that are in place are actually, that we're comfortable, that we have assurance that they will be addressing the root cause.
Thank you. So if you could report that through to the board, that would be good to close that circle when that happens. Simon.
Sorry, there was one little thing I forgot to add. In relation to those figures, and as you say, the increase in visibility, there was part of my brain that thought, is this a blip? You know, we had a sort of artificial leap. But yesterday, the first quarter report came out for Oxleas because it was the first, and we've had 40 concerns already in the first quarter for Oxleas, when we had 92, which was the final figure. So it looks as though it's continuing in that element, in that people are knowing more about the service and using it. So I just wanted to reiterate that. I apologise if I forgot.
Thank you. That's good. Can I ask a question? Because obviously you split it up by directorates, and you've highlighted perhaps some cold spots that we need to think about. If you also were to look at it in terms of geographical location, broadly speaking, those who are within the 3 boroughs or those who are outside the boroughs, obviously we're largely talking about, I think totally talking about offender healthcare, but do we have concerns that have been raised by people in Kent or southwest or outside the 3 boroughs, basically?
When it comes to the reason I divided forensic and offender healthcare last year was to enable us to look into that, and I've recently just been down to the southwest again. Concerns raised as far as offender healthcare, they are low down in the southwest, and I heard when I came in you were having a discussion, I think, about that sort of geographical mentality in relation to being separate from Oxleas. So I was quite intrigued when I did my last visit, which was just last month, both to see if that attitude had changed or if they felt more engaged, and it hadn't. Maybe in 1 or 2 of the prisons it had, oddly, but there was still that element of it. So me going down there and reminding them about the service, and I always think it's all part of the same picture of keeping people connected to Oxleas, but I think there is still a slight disconnect. From a raising concerns perspective down there, now that of course you have the internal structure of regional managers and that sort of hierarchy, which initially wasn't there when the service was first brought into it, is making a big difference in respect to people being able to be raising concerns with their line managers. As for just specifically outside of the boroughs, I don't have that data. If you want me to look into that, I can get what's going to be very busy data analytics team to look into that. And once I've got the workforce data from Oxleas, it will enable me to give a much broader picture on workforce geographics and such as workforce, etc.
I mean, it seems to me it'd make more sense with the workforce because we won't know what the denominator is really, in it is. But it does seem that we do. I think we should take care and ask you perhaps to look at, when it's next appropriate, that geographical spread. We don't want to atomize ourselves down to individual buildings because that's not going to be helpful. But I think there is a question whether those prisons that are not, those prisons are being feeling able to speak up. They certainly, I would say, from my visits down there, they do know of your existence and appreciate your visits. So they do, there is a visibility, which is good. Don't know whether being visible in a prison is a good thing or not, but okay. I mean, just to say thank you very much, Simon, and we really value the work of the Speak Up, your work as a Speak Up Guardian, and the changes that are being proposed by NHS England. I don't think will change our need to be able to make sure our staff can speak up. Nina.
I just wanted to echo your thanks, Andrew, but we get, as part of the report that comes to People Committee, some verbatim comments from colleagues who've engaged with Simon, and the value that they get, the support that they get is really very, very strong. So I'm not sure that we could do without that, and we're very grateful for his efforts with the Trust.
Thank you, Nina. That's done. Thank you very much, Simon. You're all done. You can stay with us if you like, or you can go to pastures greener if. Thank you. Okay, can we turn now to the Quality Committee, Suzanne?
So the Quality Committee papers are obviously there for people to read. There are a few things I just wanted to draw attention to. Those who are assiduous readers of the Quality Committee report will have noticed that in the past, because we hold a monthly meeting and report to the board every 2 months, there have always been 2 sets of feedback from directorates. And in fact, when I was reading the Quality Committee report this morning, I thought, oh no, there's only 1 set of feedback in there. That's because we've introduced a new system, and we're going to be asking directorates to feedback to us once a year in future, but we're creating more space within the committee to have a good discussion when they do feedback to us. So I wanted to assure people that we had not forgotten one of the directorates that reported. The second thing I wanted to draw attention to, because I think it's been a bit of a theme of the discussion today, is around where we've got to with understanding health inequalities data that get reported to us. Because I think what's quite striking is that we're gathering the data and it doesn't necessarily make sense of itself. And so we've had some quite interesting discussions in the committee about what to make of data that, for example, suggests that there may be, and this was one of the discussions that we had at the last committee meeting, that an apparent disproportionately high number of women involved in incidents may be because there's a disproportionately, it is difficult to tell how that relates to the proportion of women within our population of service users. So there's quite a long way to go, I think, before we understand what the health inequalities data are telling us. I wanted to draw attention to one item which people might not have picked out of the report, but I think is very positive, is about the progress made on bed management and the reduction in length of stay for patients, because people may be aware that this is going to be part of the new performance assessment framework, that will be judged on how many people are in our inpatient beds for longer than 60 days. And I think it's quite remarkable that in the last year, we've brought down the average to 62 days from 100 days a year ago. So there's been an awful lot of work has gone into that. And I think it's good that we've made progress in advance of the performance assessment framework. I also wanted to mention 2 other items which are in these, one is about Health Watch. People who read the annual report, and we looked at it closely in the committee on behalf of the board, will have seen that Health Watch have always been asked to look at the report, the quality aspects of it, and to comment on it. And their comments have been incredibly helpful. So I think that, taking this forward, we really need to make sure that we continue to have the kind of engagement with our local communities that Health Watch has offered us in the past, because what they identified in the annual report was that there's lots of really good work going on in relation to quality, but that we still have a challenge as in terms of patient families' perceptions of being engaged in the triangle of care. And that came out of both of the Health Watch's comments. So that sort of relates to the final thing that I wanted to comment on, which was about the progress which is being made on the triangle of care risk. We've been looking at this closely since since the work of the service user and carer shadow committee, where they looked at the engagement risk for us and offered some very interesting comment. And the thing I just wanted to draw attention to is, although we're still looking at that risk and it's still on the risk register, there's been some really good work done in response to that risk. And some of it kind of leaches out in conversations and doesn't necessarily get reported. But you will have noted that there's a new carers and confidentiality policy, and our people with lived experience have been going out and providing really good training on this. They've developed a training program that engages people who have experience of care, and I think that there's been some very positive progress made there.
Thank you. Questions for Suzanne? Thank you for that one. I think that one of the things that as well, we're going to have to keep an eye on several shifting things. The Health Watch, I think you've already highlighted. Also, it's clear that there's NHS England, as is now, is going to send more data down to the trusts, which they will be using and making that more transparent. So actually, I think there's a whole load of shifting things in here over the next few months that we're going to have to be cognizant of as it happens. But thank you for that report, Munisa.
Just a comment, really, just to congratulate you or commend you on the changes that you're making for the Quality Committee. I'm not on the Quality Committee anymore, but it's got a huge breadth of agenda and takes responsibility for so many things. And it's great to, see sort of innovate and try to kind of improve. I think it's us walking the walk. Jane gave a statistic when it was discussed about how many hours we expect it to save, and we'll make a decision sort of 6 months from now, obviously, but it's great to see us be proactive to try to do that.
Excellent. Thank you. Jim?
Thank you, Chair. And I do miss Quality Committee. Not the 300 pages I have to read through, but the data is really interesting. So this is my first BIC, and I'll just highlight a couple of points. Month 2, we're break even, but as Azra would say, that's non-recurrently. And so we're keeping an eye on that. We understand there's an overhang from last year, and we're just getting going with some of our programs, but we have to keep an eye on our monthly stats. We had some information from SEL ICS, break even, but again, have to keep an eye on that because there's this big hole around Kings, and we have to see how that's going to play out for the rest of the year. There's an increasing focus on the PFI as we go through. It is getting quite tight time-wise in terms of the decision points that we have to make, and so we'll be establishing a PFI subcommittee. I think that I will be chairing out of BIC to keep an eye on that, because if the timings do slip in a major way, we may have to make decisions without having all the information that we need. And when Simon's here, I'm sure he can attest to that. We have an increasing focus on living within our means, and thank you to Ian and his team for all of that. We will be getting reports from there on a quarterly basis, but at the moment we're getting verbal reports on a monthly basis at the moment to see how it's going, and that seems to be progressing. The plan and the implementation of that plan is going forward. Hopefully in the July BIC we'll get that report, I think. And Simon presented a workplace strategy as well, in terms of the estate and utilisation, and it's really interesting how that was developed and co-developed with staff and going forward, and that's a really, really good programme coming forward. And there was a successful pilot memorial. Last 2 points, capital plan is going forward again. They assure the board that we're on top of that. Our terms of reference have been updated with living within our means, coming into the reference, and there we have a continual focus on the cyber risk and cybersecurity with Alison, and a focus on third party, which is an area that we're looking at as well. I think that's it, really.
Thank you, Jim. Any questions for BIC? No, and thank you. And I think it'd be good to understand sometime a little bit more, I think, about this using the estate strategy a bit more. You at the moment, could you perhaps just say a bit more about it, Jim, or maybe bring Simon in if necessary?
Over to you, Simon, probably.
In terms of the workplace strategy, yeah. So I think we've been on a bit of a journey at Oxleas in the last few years since I arrived, to try and understand how our spaces are used and how we can better use them. So we've had motion sensors in place to give us some base data, or I want to make decisions based on data rather than hearsay and historic working practices really. So it was part of to give me an understanding of how we use our estate. So across the estate, our average use is sort of 35 to 40%, which is not great, but not unusual at all across the country. So I wanted to use that data, but what I think, not a wall I hit, I suppose, but it was about understanding how the teams want to work. Lorraine's gone. We've debated this many times, myself and Lorraine. So, our clinical teams need to still have a sense of home, a place where they can come together and collaborate. But then equally, we've got these pressures about reducing our estate and sweating our assets as well. So there's a lot of conflict. So essentially, I just produced a strategy to try and help us on a case-by-case basis address those problems really, so we can get what everybody wants. I always say to the clinical teams, give me your gold standard, tell me what that looks like, and then we'll see if we can achieve that and see if we can match that out. So it was just a sort of a new cultural co-produced way of thinking about how we adapt those spaces. So we tried to do a piece of work at Memorial a couple of years ago using that data. I think the data is very robust. It's used globally, nationally, within the healthcare system. We're really ahead of the game in terms of South East London for sure. Everybody else is just picking this stuff up now. So I'm quite pleased from that perspective that we're leading the way, and I'm sharing our data and our reports and bits and pieces with people, with other trusts and organisations across London. So that's sort of where it was born out from really. And we'll see how it goes. So we're going to start the Memorial programme again. I think when I arrived here probably 4 years ago, we were just coming out of COVID. People were working differently, and obviously there have been clinical concerns around people seeing patients virtually. And I think there's a lot more focus about face-to-face and understanding that people were going to come back to the office a bit more. I think it's different, for me and Azra in corporate teams, we can work very differently, but we still need to make sure our clinical teams have got that space. But also they're working differently as well. So it's a case of providing these smaller spaces for them to do Teams meetings, supervisions, and all this sort of stuff. So it's a bit of a whole bit of a cultural shift. We've started a QI project as well at High Point with the CYP team over there as well, which again hasn't progressed as well as I wanted it to, but we're going to have a bit of a reset about how that works, because I need the teams to sort of take a bit of ownership about how they work themselves. And maybe it can change and maybe it can't. I don't know. I've reached the end of my skill set in terms of estate. So it comes around to the culture about how appointments are booked, how people are managed, how they manage themselves, I suppose. So, and I want to say to the clinical teams that I do to the CYP director, and I've said this for the last 12 months, it's within their gift to give to try and manage those spaces. And they've all got lots of individual teams, as you know, so all with conflicting agendas, and they actually all work very differently, so it's quite interesting. So hopefully I want to bring back a few successful examples to the board in say 12 months time, where we've managed to use that strategy to improve spaces and get what everybody needs.
And I think the essential strategic challenge is that we've got a utilisation which is not abnormal at 35%, and the target, I think we're looking at 60 to 80%. How do you get from there to there it can't be a top-down approach. It must be working with the teams and co-developing that strategy with the teams, and that's what Simon's doing. So it's a hard task, and each team operates in a very different way. So, but I do think the strategy is in the right direction, because there's a process in which there is consultation with the teams, there is co-developed, and hopefully through that mechanism we can drive it forward.
Thank you. It sounds like an area we need to keep an eye on for progress. Thank you. Okay, we'll skip backwards if that's okay to Jane. Can you do the mortality work?
Thank you very much. This is the Q4 Mortality Surveillance Committee report. It's been through the Quality Committee, so I will take it as read. But I wanted to really highlight the review that we looked at, which was the National Child Mortality Database Programme thematic review, looking at 3 years data on deaths of children with learning disability and autism. There's some really interesting data there around inequalities and causes of death, which resonates with our own information, our own leader reports within South East London as well. So we're really pleased that Jenny is now the director of CYP, our Children's Services, and brings that wealth of learning disability and autism experience. And they are continuing with the work, which again resonates with the themes from the National Review around improvements that they continue to make. So I think we're on track, and it was quite reassuring for us, even though it's a very difficult and sad read.
Thank you, Jane. Questions, Jim?
More of a comment, really. I'm sort of privileged to be on the mortality committee now, the last few, and I just want to say to the board that I'm really impressed with the committee and how it operates, and particularly so that the last mortality committee that we had, we were talking about sort of obviously a very hard topic of the multiple deaths within the trust, and the professionalism that the team has, but also the fact that a lot of the team know our patients and service users personally. So they really understand so it's a real care and compassion that's coming all the way through, and it's a credit to the committee and yourself, Jane.
Thank you, and I think that ties nicely into our discussions earlier in the strategy and whether there's some learning there about the way in which we can evidence the care and commitment that we show and the empathy. Compassion is the right word. So thank you for that. Okay, People Committee, Nina.
Thank you. So starting with safe staffing, this is an exercise that we do twice a year to establish whether we have safe staffing across acute and crisis, forensic and Meadowview. And it's primarily using a tool that's called the Model Hospital Optimal Staffing Tool, if I've got the acronym right, Jane. And first off, Jane and Julie have done a phenomenal amount of work on the analysis that sits behind this report. So the quality of the report and the value that we get from it has come on in leaps and bounds over the last couple of years. It doesn't mean that there aren't things that are slightly uncomfortable within the content and within the data that we're looking at. So you see picked out in the report that within Avery and Shrewsbury, which triangulates in an interesting way and an important way with what Sophie shared, they are the highest scoring wards for acuity and dependency, and that is the same pattern that we have seen in the last two safe staffing reviews. And so what you would expect to happen is you would look at the recommended staffing and compare that to budget and actual staffing, and there is a gap. So the challenge from People Committee was, why are we not filling that gap? Why are we saying that we are going to have a further period of intense support in terms of rostering practices? And that goes to, and there were a couple of other areas that were in a similar place, that goes to, so it was interesting, we had a discussion around how the safe staffing data triangulates with other information that doesn't find its way into that report, but that is clearly an important factor in considering safe staffing. So that goes to patient experience and feedback, qualitative measures, incidents, professional judgment. So we have a follow-up session in August to just explore how all of those triangulate and to make sure that when we're bringing the safe staffing report to People Committee and then to the board, that we are presenting all of the information that goes to safe staffing conclusions rather than just what we need to do based on MHOST. The reason that we support the continued focus on refining rostering practices is because there has been a journey over the last couple of years to really improve practices, and we talk about going back to basics and getting the basics right, and some of this really is basics, but important basics. So focusing on things like unused roster hours and how we plan and manage for unavailable hours. So that work is progressing in the right direction. As I say, we have a follow-up in August, Muniza, Martin and myself with the exec, just to go through that in a little bit more detail. You'll see that the report references that there has been a recommendation to increase night staffing at Barefoot Lodge that is being taken forward, and that there was a recommendation to increase the establishment on Heath Ward that is also being taken forward, albeit with some delays because of the steps that were required to secure SLP approval. The other thing that I would like to call out is the position on health and safety audits, where unfortunately, and we will bring this back to board when we have the annual health and safety report, which will be in September, there has been a quite significant drop in the trust-wide average scores for general risk assessments, a fall from 82% average in 23-24 to 68% in 24-25. And the reason that this matters is because the quality of the risk assessment determines the quality of the approach that we take to health and safety overall. So it's kind of starting point. So EXCO has agreed with the support of the People Committee that the health and safety audit programme itself will be paused in 25-26 to enable and to provide that space for workshops that are designed to, in a tailored way, improve knowledge, understanding and confidence amongst those team managers who are charged with completing the risk assessments. And then we will go back to the ordinary programme of health and safety audits from 26-27. So those were the key, in addition to freedom to speak up, those were the key themes of the last People Committee. We'd also alert you to the discussion that we had, which again we will follow up at our deep dive meeting in August, around the removal of the apprenticeship levy for level 7 apprenticeships from the beginning of 26, which is obviously going to have a big impact for nurses. And as I also trailed before, the other topic for our deep dive in August will be the increase that we've noted in sickness absence amongst senior staff due to anxiety, stress and depression. Happy to take questions. There's an awful lot of good news, I would say. There's an awful lot of really positive steps forward and work that is being done. Happy to take questions on all of it.
Thank you very much. We're obviously starting this area in a demonstrably good place, but we are not going to be complacent about it. And you picked some good things too that we need to be on top of. Thank you. Any questions or comments? Suzanne.
Sorry, I had a little dig around in the background reading because I was curious about the workplace disability equality standard outcome. And I wonder if we're a little bit complacent about how well we support staff with disabilities. I was struck that reading on LinkedIn this month that that July is apparently Disability Pride Month, which was news to me. And I think just looking at data that 75% of our staff are satisfied with the reasonable adjustments which are made for them with disability. My understanding is that it's a legal obligation for us to make a reasonable adjustment. So I wouldn't have rated it as green that 75% of our disabled staff think the reasonable adjustment should be made. I think that should be 100%. So I just wondering what the view was on People Committee about that.
I think it's a very fair challenge. I remember when you were on People Committee, we had a number of discussions around the time lag when somebody is classified as eligible for adjustments and us being able to actually put those adjustments in place. And we talked about what practical steps can we introduce as workarounds. I don't detect complacency at the level of the team, but I think you're absolutely right to pick out. Sometimes when you get all of the data for the res and the des, sometimes you can not spot things that you've just highlighted. So I will take that back to People Committee, and we will have a discussion on the point that you raised. Thank you.
Thank you. Can I turn, Damien can't be with us today, but has agreed to take us through the Audit and Risk Committee and the signing of the accounts. Thank you.
Thank you, Chair. So the Audit and Risk Committee has met formally twice, once on the 18th of March, and that was principally, I'm going to say, quite a heavily internal audit based audit committee, where we took the final head of internal audit opinion from KPMG, our internal auditors, and we had a fairly positive outcome from that. We also signed off the 25-26 audit programmes for both internal audit and for counter fraud through those meetings. There was an interesting, I would say, report that they had done, which was a comparative report around procurement that had laid us out as broadly similar to other organisations. I'm just checking if there was anything else really to highlight from the rest of that meeting on the 18th. I think that those were probably the key themes from the 18th. The committee did also go through some amendments to the standing orders. They were quite minor, I'm going to say, just literally, I think, changes to people's titles, but nothing else too major. We also approved the NHS England provider licence self-certification on the 18th of March, which was something that we formally needed to do and went through that. We went through the declarations of interest register and gifts and hospitality register to check that they were reasonable in terms of sign off. That was done more at the 17th. So, and lastly, we went through the terms of reference to make sure that they were updated. The 17th of June meeting was then the meeting that we were supposed to be taking the final set of accounts. If I just highlight what's happened in that meeting, then I'll give an update of what happened after that meeting. We went through the set of accounts. They had already been through a page turn with Damien. And just to remind the board that the board had delegated the sign-off of the accounts to the audit committee and then to Damien as chair of that audit committee if there were any issues coming thereof. The accounts and the annual report were gone through at the meeting. There were some changes that were requested and they have actually been put through the final set of accounts and the final annual report as it's come through. As I said, we went through the declarations of interest and they were all signed off at that meeting, as well as the letter of representation. So just for people that are thinking, what is that? That is a letter that the external auditors ask management to sign off to give them further assurance before they sign off the accounts. That was also approved at that committee. We did not have the final audit findings report for the 17th of June and also the auditor's annual report because they still had not completed their work. There were 3 areas that were outstanding as at that date, and that was some further work they needed to do on accruals, on deferred income, and on valuations at the Queen Mary site. Since the end of the 17th of June, we continued to work with the external auditors, and I am pleased to say we finalised and got the audit recommendations final report out yesterday, and that is when we submitted our accounts. That was 2 days after the national deadline, but they were given with no qualification on the accounts, no changes, importantly, in terms of the control totals. So the final figures that were submitted was a £2.8 million surplus. There was an updated audit findings report. Damien went through both the final version of the annual report, the final version of the statements, and the final bridge. That was emailed out to other audit committee members yesterday once we had the final reports. And the final audit findings report will come to a future audit committee for the audit committee members to have a look through. But everything has now been submitted to NHSE in line with the requirements.
Thank you. I've got a few things to say, but first comments or questions on that. I will say, I want to congratulate the team, everyone actually on the clean audit. I think that's really good. And it's very good. It has been a lot harder work this year than it should have been, not because of internal processes, because of goalposts that seem to be changing on a continual basis, and I just think we need to acknowledge the hard work of Sat and Alex and Nazra actually as part of the team. It's been absolutely fantastic. I know Ify and myself also have been involved in the last few days, obviously with the final sign off, but it's been a very difficult, it's been a very, not difficult, perhaps a very laborious process is perhaps the way to do it. And I think Damien's also deserves our thanks. And if it's okay, I'd like to, perhaps write as chair to the people who've done that one, because I know it's been a lot of work for your team as well this day.
And that would be very much appreciated. And I should have mentioned this, but Suzanne actually had an intervention at the 17th around one of the recommendations that was around Rio. And I'm pleased to say that recommendation was removed from the final report. So a very timely intervention there, Suzanne.
And also just to say that one of the things that we're going to do is, because of the new audit, and I talked to Damien about it this morning actually, because of the way in which the audit is being interpreted and perhaps the greater scrutiny that's happening, and I don't think that's unique to Oxleas. There's another body, an NHS body I'm involved on, which is having when I say difficulties with the audit, I don't mean difficulties in terms of what the audit findings are, but a lot of work having to be done on it. That what we're doing, and we've already called a meeting for September, a workshop meeting for us to think about how we respond as a trust and what we need to do as a board to enable things to be carried out next year as they should be carried out, I think. So dates are already going to people's diaries in September for that. But thank you.
Andrew?
Yes.
A question, and thank you, just echoing all the thanks for the work they're done. Are there any implications to the audit, the accounts being filed a few days late? I mean, I appreciate all the reasons for it, but is there a consequence to that?
There won't be. We notified them really on Friday that we thought last Friday that we thought they could be at risk, and we've been monitoring and keeping them up to date. And I think they were comfortable. I think if it stretched too much beyond yesterday, there would have been a consequence in terms of final laying before Parliament, but we were able to avoid that outcome.
Which is different from my other body.
And just to say, as far as actually publishing our annual report and accounts, we have to do that within 6 months of the end of the financial year. So the next stage is that we take the narrative and we lay it out into a document that will then go to Parliament, generally when Parliament reopens in September.
Yes, as somebody who's not totally immersed in Parliament, I just imagine this table in Parliament with all the NHS trusts, papers laid on them, but I'm probably being a little bit old-fashioned. There's probably somebody with a magic wand or something that lays it. Okay, if we could turn to the last one, which is the Council of Governors report, which is my report as chair. The Council of Governors met fairly recently, and the report is here. The things to report on, I mean, I'll take it as read, except to congratulate Suzanne on her reappointment as NED by the Council of Governors, and also say the councillors, trying to remember whether they recommended or they approved. I think they recommended a change in their terms of reference in terms of the of a particular group of people, partner that should be part of it. Sally, do you want to summarise that?
Certainly. So the council, what we took to the Council of Governors was a proposal to remove a service user carer constituency. This was something that had been introduced in 2018 to have a specific group for people who use forensic and offender healthcare services, as an idea of just making sure there was representation. However, in that time, it has been very, very difficult to recruit people because of the necessary barriers that there are in place in communications with people in prison and in some of our forensic services. So we've reviewed this with the membership committee, and also because we've since made changes to how our constituencies are constructed, it means that these people can join other constituencies. So, the people that can join and want to join, there are opportunities for that. So therefore, rather than running with an empty, vacant governor seat, we're suggesting that we remove this constituency. So the Council of Governors agreed that, and then for us to take it forward to the membership at the members' meeting, we also need the board to agree to that change of into the constitution. So I ask you to agree to that change.
Are people happy? Seeing nods around. I mean, I think in many ways it was obviously a good attempt to try and include a group of people who should be included, but it just wasn't practical for fairly obvious reasons. Okay, thank you. Review of today's meetings. How did people think today's meeting was? Were we able to kick the tires sufficiently rigorously for the trust? I'm seeing some nods around the table. I thought one of the things we did slightly differently today was I thought the NED reports were slightly more, shall I say, at a meta level, and I personally welcomed that one. And I think, as we sort of synthesized it rather than went through all of our reports, we summarized our reports and pulled out the themes, and pulled out themes from other bits of our roles as NED, not just the visits. I personally would encourage that. I thought that, to me, that was in a way more useful, if people are happy with that. Any other comments around today's meeting? Yes, Suzanne?
I feel that I shoved you into doing a written chairs report, but I found it very useful. And the written summary of the outcome of the board review, really crystallised for me, what had been done. So thank you.
Thank you. And Manisa also was able to pick up from that one and have some questions that we'll deal with outside the meeting, but that was from that summary, I guess you saw that, so that's good. Okay, thank you very much. The forward agenda is there to note, to agree, but I think we note it. Anyone else got any other business? So we've got part 2 of the meeting coming up. I'm going to suggest we have some lunch. How long do people want as a break for lunch? It's 10 past now, half an hour. I'm sorry, 20 minutes, so we start at 1:30. And if people are still eating sandwiches when they're working, I think 20 minutes of leg stretch is important, but people can bring whatever they're eating to the table at 1:30. So we'll start again at 1:30. Martin, is it okay with you wherever you are? Well, we could send round some ergometric expert to help you, but maybe not. Okay then. Thank you, everyone. So we meet again at 1:30. And for those who have been listening online or are listening in catch up online, thank you for listening. And hopefully you were able to gain something about the way the Work Trust works through this. Thank you very much.